Good morning, everyone. Welcome. This is the last grand rounds for this academic year. So hopefully Dr. Tremblay, Schiano, Patel are going to knock it out of the box today, hopefully, right, for our final grand rounds. So with that, I'll turn it over to Dr. Jordan to introduce our speakers.
Thank you, Dr. Thomas. Good morning, everyone, and welcome to Grand Rounds. It is my pleasure to introduce today's speakers, Dr. Douglas Tremblay and Dr. Thomas Schiano. Dr. Tremblay is an assistant professor of medicine at the Icahn School of Medicine at Mount Sinai. He completed both residency and fellowship training at the Mount Sinai Hospital. He served as an educational leader, founding and running the inpatient oncology curriculum and the clinical research curriculum for the Department of Medicine. His clinical and translational research is on hematologic malignancies, particularly acute myeloid leukemia, myeloproliferative neoplasms, and myelodysplastic and myeloproliferative overlap syndromes. Dr. Tremblay has led multiple multi-institutional research efforts in MPNs and is actively involved in both investigator-initiated and industry-sponsored early and late phase clinical trials on myeloid neoplasms. He has more than 70 peer-reviewed publications. Dr. Thomas Schiano has a clinical background in hepatology, gastroenterology, and clinical nutrition, with expertise in the management of acute and chronic liver diseases and in caring for patients prior to and after liver transplantation. Dr. Schiano has clinical research interests in alcohol-related liver disease, recurrence of disease post-liver transplantation, and management of the complications of cirrhosis. Dr. Schiano is UNOS certified and board certified in internal medicine, clinical nutrition, gastroenterology, and transplant hepatology. He completed fellowships in hepatology and liver transplantation at the Mount Sinai Hospital, gastroenterology at Temple University Hospital, and clinical nutrition at Memorial Sloan Kettering. He completed residency and chief residency in internal medicine at Maimonides Medical Center. Dr. Schiano is a professor of medicine at the Icahn School of Medicine, medical director of the adult liver transplantation, director of clinical hepatology, and medical director of the intestinal transplant program at the Recanati Miller Transplant Institution at Mount Sinai Medical Center. A very warm welcome to both Drs. Tremblay and Dr. Schiano.
Great, thank you so much for the introduction. We're also joined today by Dr. Patel, who is from Interventional Radiology, and we'll be giving a lot of great context for that. He did his, I'm just looking online, he did his MD at University of Miami, and then his radiology residency at Jackson Memorial Hospital. And he actually was an intern with my mentor, John Mascarenas, so lots of good stories there. So today we are going to be speaking about a very niche subject, but one that I think is really important and applicable, and one that is uniquely focused to our Mount Sinai patient population, and that is splanchnic vein thrombosis and myeloproliferative neoplasms. And so what we'll be discussing today is our current concepts about this very small topic that has a lot of internal medicine applications. And instead of just giving a talk about this, I thought it'd be great to do this multidisciplinary grand rounds and invited my good friends, Tom Schiano and Rahul Patel, to also give their input. So here are our disclosures. So our objectives for this morning are to describe the epidemiology, the diagnosis, and the clinical features of splanchnic vein thrombosis and myeloproliferative neoplasms, which I'll be speaking to as referring to as MPN SVT. We're also going to assess the current pathobiologic understanding of MPN SVT and the limitations of that, and spend most of our time talking about the optimal management of these patients, including anticoagulation, cytoreductive therapy, endovascular intervention, and then hepatology management, especially liver transplantation. So just to orient everyone, this is a great figure that was made by our medical illustrator, Joe Gregory, that lays out the anatomy of what these splanchnic vein thromboses are. So specifically, splanchnic vein thromboses are these extrahepatic thromboses that occur either in the portal vein most commonly, or either the left or right branch of the portal vein, or the splenic, mesenteric, inferior mesenteric, or superior mesenteric veins. They also can occur in the hepatic vein, which is called Budd-Chiari syndrome. And it's important to recognize that there's differences in these types of thromboses in terms of clinical presentations, where hepatic vein thrombosis or Budd-Chiari syndrome is associated with much more severe and acute presentation, while these portomesenteric thromboses often can occur together and have a more of a less symptomatic presentation. So when we refer to splanchnic vein thromboses in this talk, we'll often be referring to all of these types of thromboses, but at certain times we will refer to portal vein thrombosis specifically or Budd-Chiari syndrome specifically. The other part of this is myeloproliferative neoplasms, and specifically Philadelphia negative myeloproliferative neoplasms. So these are a group of disorders that are interrelated both clinically and pathobiologically. And they really start at the level of the stem cell, where there's these mutations in specific driver mutations, the most common being JAK2 V617F, calreticulin, or MPL. And these really exist in this clonal hematopoiesis, which we heard a talk a few months ago by our colleague, Dr. Marcelino, about CHIP mutations. It really starts at this level. And then through different cellular and biologic events in certain patients grows out into a proliferative form. And this includes polycythemia vera, which is characterized by a high absolute red blood cell count, high hematocrit, high hemoglobin, or essential thrombocythemia, which is characterized by a high platelet count. And the real clinical complication and the main driver of morbidity and mortality are vascular events and thromboses. And this typically stays in this form for typically years, and many patients will stay in this proliferative version of MPNs, but some patients will progress to myelofibrosis. And patients also can be primary myelofibrosis. And at this stage, instead of cytoses, you see cytopenias frequently, progressive constitutional symptoms, fevers, night sweats, weight loss, and then egress of hematopoietic elements to the spleen, causing extramedullary hematopoiesis and splenomegaly. And in some patients, even further mutational biologic events occur for the disease to progress into a particularly acute version and a particularly mortal version of acute leukemia, what we call MPN blast phase. So these exist along a continuum, and we're going to be talking about many of these today as well. But I want to make sure that it's understood that really that there's a lot of different types of clinical syndromes that are associated with these different versions, but that they're interrelated. And why they're really interrelated was found in the 2005 with the identification of the JAK2 mutation, which really binds a lot of these diseases together. And later on in the early 2010s with the identification of the CALR mutation, the MPL mutation. So in polycythemia vera, which again is clinically characterized by erythrocytosis, nearly all patients have a JAK2 mutation. While in essential thrombocythemia, JAK2 mutation is present in about 60% of patients, and a calreticulin mutation is present in about 25%. And MPL, which is the thrombopoietin receptor mutation, is present in about 5%. While in primary myelofibrosis, it's about 60%, 30%, and 5 to 10%. So these mutations we will be speaking about too, because they also have a great deal of importance for the pathobiology of MPN splanchnic vein thrombosis, and are very important in the diagnostic workup of this disease. So just a bit of history, which I think is just interesting to know about, is that this was really first identified Budd-Chiari syndrome as a clinical entity by the British internist George Budd in 1845. And then 54 years later, the Austrian pathologist Hans Chiari, he really noted the first pathologic description of the liver in a patient with a thrombosis in the hepatic vein, which he deemed obliterative endophlebitis of the hepatic veins. But it wasn't until 1929 where polycythemia vera, one of the MPNs, and Budd-Chiari were really first described in a patient. And then 10 years later, there was a New England Journal of Medicine case report of 8 patients with splanchnic vein thrombosis who also had a myeloproliferative neoplasm. And this really sparked further investigation into this connection. So just a minute about the epidemiology, because I find it very fascinating. And we'll also speak about the prognosis. So splanchnic vein thrombosis and MPNs are both rare conditions. So here's from a meta-analysis that was recently published about about the different incidence of and prevalence of these different MPNs. And you can see that the incidence of ET and PV ranges from 1 to 2 or 0.5 to 4, and PMF is the rarest with an incidence of 0.3 to 2. While because these patients live for a long time, the prevalence is much higher in ET and PV, with a prevalence of 24 to 58 per 100,000 or 22 per 57 per 100,000. But because of the shorter life expectancy with PMF, the prevalence is shorter in PMF. Meanwhile, the incidence and prevalence of portal vein thrombosis and Budd-Chiari syndrome are also quite rare, with an incidence around 0.7 for portal vein thrombosis, and even rarer for Budd-Chiari with 0.1, and a prevalence that again is shorter because of shorter life expectancy of 3.7 per 100,000 and 1.1 per 100,000. Now, these are both two rare conditions, so you would assume that the prevalence and incidence of them combined would be extremely low. But among patients who have portal vein thrombosis and who had a myeloproliferative neoplasm workup, about 32% of patients were found to have an MPN based on one meta-analysis. And in Budd-Chiari syndrome, that is up to almost 41% of patients. So clearly, patients who have these splanchnic vein thrombosis are enriched for MPN patients. And we'll explain why in a minute. But I also wanted to say that there's other causes for splanchnic vein thromboses outside of MPNs. And this is from two different series that looked at portal vein thrombosis and Budd-Chiari syndrome, what really caused them. And as you can see, cirrhosis is very common as a cause, solid cancers, inflammation, surgery, frequently gastric bypass surgery or bowel surgery, as well as pregnancy and hormonal therapy. And MPN in this series only made up 7%, but given that the span of patients lasted a long time, many of these patients may have not had an appropriate workup for an MPN. Idiopathic portal vein thrombosis is also an interesting entity too, and it's estimated about 20 to 25% of patients don't have an identifiable cause. Budd-Chiari syndrome, in contrast, is much more enriched for patients who have a myeloproliferative neoplasm, as well as rheumatologic hormonal causes. But within MPN patients in general who have a splanchnic vein thrombosis, there's certain types of MPNs that really are common for splanchnic vein thrombosis patients. So this is a series of from Mount Sinai that we published a few years ago, looking at patients who have a myeloproliferative neoplasm and a splanchnic vein thrombosis. And what you can see is that the splanchnic vein thrombosis patients very frequently have these proliferative versions of MPN, polycythemia vera or essential thrombocythemia, and less frequently have these myelofibrosis, primary myelofibrosis or secondary myelofibrosis. Another interesting fact that we uncovered was that many patients had this MPN unclassifiable, which is kind of this catch-all term for MPNs that don't meet pathologic criteria for any of the other ones, but clearly have features of MPN. And this is a rare disease, but it is also enriched in splanchnic vein thrombosis patients. Another interesting feature about MPN splanchnic vein thrombosis is that it's actually more common in younger patients than older patients. And this goes largely against other thrombotic risk factors where age is thought to be a risk factor for thrombosis, particularly among MPN patients. As you can see from this series from Brady Stein at Johns Hopkins at the time, they looked at thrombosis history in two populations of patients, less than 45 or greater than 65. And what they found was that there's no difference in the rates of thrombosis, although arterial thromboses were much more common in older patients. But what was most striking is that nearly all the patients, 13 out of 15, who had a splanchnic vein thrombosis were less than 45 rather than greater than 65. So it is very well shown in multiple series that younger patients have a more potent risk for having a splanchnic vein thrombosis rather than older patients. Another interesting feature is that MPN splanchnic vein thrombosis is more common among females versus males. So this is another study from the Johns Hopkins group that looked at women versus men in different types of thromboses. And while you can see DVT and PE and acute coronary syndrome and peripheral artery disease are more common among men than among women, there is about twice as likely to have a splanchnic vein thrombosis if you're a female versus a male. And even within our series of patients, nearly 3/4 of the patients were female versus male. So again, epidemiologically, it seems that these patients are younger and are female versus older and male, which again goes against a lot of thrombotic risk factors that are traditionally seen with MPNs or elsewhere. In terms of prognosis, it's important to note that even with anticoagulation, MPN splanchnic vein thrombosis rarely resolve or recannulize. So this is a study and a data set that was pioneered by my friend and colleague, Lenny Namagon, that we looked at different times to recannulization. So obstructive portal vein thrombosis, and seeing at rates it was either non-occlusive after becoming occlusive or just went away completely. And we looked at these different risk groups based on what they were found their etiology was initially. So if you had a known etiology such as an abdominal surgery or pancreatitis, you had about a 50% chance of recannulizing at 24 months. However, if you didn't have any known risk factors, your risk for your chance of recannulization was significantly lower, around 40%. But what we've really noted was that if you have a JAK2 V617F mutation, that your rates of having recannulization is extremely low, about 20%. And if we looked at just complete resolution of the portal vein thrombosis, essentially 0 patients had complete resolution. So this suggests that this is an ongoing thrombotic stimuli and that it is something that continues to exert a thrombotic tendency. And even with anticoagulation, the thrombosis does not resolve. Patients frequently ask, is this going to affect my overall prognosis? And this is a study from the Spanish group that looked at 118 patients who had polycythemia vera, central thrombocythemia, and had a splanchnic vein thrombosis. And after correcting for age and sex, patients who had a splanchnic vein thrombosis had a decreased overall survival versus patients who didn't. Although survival was generally very favorable in both groups, around median overall survival around 15 months versus around 20 months. But what this was also showed is that what patients really die of who have a splanchnic vein thrombosis and an MPN is really from causes that are in complications of the splanchnic vein thrombosis and not of the myeloproliferative neoplasm itself. So in this, they noted that cardiovascular deaths were caused, but they also looped in bleeding, brain hemorrhage, hemorrhagic strokes, and liver failure as other causes here. And that transformation to acute leukemia, it happened in 0 of these splanchnic vein thrombosis patients. So a lot of the complications in the mortality associated with MPN splanchnic vein thrombosis is from the thrombosis and not necessarily from evolution of disease. So now we're going to speak for a minute about the pathobiology of MPN splanchnic vein thrombosis and really focus on endothelial cells because that's where a lot of the current research is on. So this is a really interesting study that was really pioneered by Isabel Fiel and one of my mentors, Ronald Hoffman, here at Mount Sinai, where they early on after the identification of the JAK2 mutation, they wanted to look at liver biopsy specimens, and they did a technique called laser capture microdissection, where they actually just excised out the endothelial cells and then evaluated for the presence of the JAK2 mutation with PCR. And they did this on 3 PV patients who had a Budd-Chiari syndrome and 2 patients who didn't have PV but had portal vein thrombosis. And what they found is that in 2 of the 3 patients who had Budd-Chiari syndrome and polycythemia vera, they were able to detect the JAK2 mutation in the endothelial cells themselves. 1 patient didn't have this present, and then 2 of the patients who didn't have PV and had a portal vein thrombosis, they didn't have JAK2 mutation. So the JAK2 mutation actually lives within the endothelial cells itself. And this is a later study looking at 18 JAK2 mutated myelofibrosis patients who had a splenectomy for therapeutic reasons. And then they did a similar technique looking at the splenic capillaries, and they found about 2/3 of patients had cells that harbor the JAK2 mutation. So this raises the idea that there may be this hemangioblast, which is this common cell of origin between both hematopoietic and endothelial cells that is mutated at an early stage and then differentiates into both. Although this idea is widely debated in the field. What is the consequence of the JAK2 mutation in the endothelial cells? So this is a study from Alexander Guy and Bordeaux, France, where they developed this cool model where they had endothelial cells that overexpress JAK2, but granulocytes, white blood cells that are JAK2 wild type. So looking really at what the effect of the JAK2 mutation is in the endothelial cells themselves. So these mice had a higher propensity for thrombosis, and especially whenever you had inflammation, which they gave TNF alpha, you see that the leukocyte adhesion, which is a marker of thrombosis, was significantly elevated in JAK2 mutated patients versus control. They also found that there is a significant increase in P-selectin and a higher expression of P-selectin, particularly in the JAK2 patients whenever they were exerted to inflammation with TNF-alpha. And then they showed this on the carotid endothelial cells that increased P-selectin staining, which you see in the green, is present whenever there's a JAK2 mutation versus when there's not. They also showed that blocking P-selectin decreased the risk of thrombosis. So in a company editorial by my colleagues, Drs. Barnaton and Hoffman, they showed this really excellent figure, which I think ties a lot of things together, where you have the JAK2 V617F mutation, and that causes increase in endothelial cell ribopolyd body degranulation of P-selectin involved Willebrand factor. And at the same time in the granulocytes, you have translocation of RAP1 towards the cell membrane, and that causes activation of these integrins, LFA1 and VLA4, in addition to increased neutrophil extracellular trap formation. And all of these events coalesce together to cause a thrombosis. But it really starts with this JAK2 mutation, both in the endothelial cells and in the granulocytes. There's other roles of the endothelial cells. So this is a figure that was made by one of our collaborators, Joan Beckman, University of Minnesota, and looking at the different ways endothelial cells cause thrombosis in MPN splanchnic vein thrombosis. So through endogenous JAK2 V617F expression, you get exposure to different cytokines, as well as increase in these different tissue factors in these adhesive molecules, ICAM and P-selectin, causing thrombosis. There's also increase in factor VIII, as well as von Willebrand expression that causes endothelial cell activation and thrombosis. And then also through expression of VEGF, there's abnormal cell growth, which can cause cavernous transformation of the splanchnic vessel, as well as a disrupted barrier function whenever there's pro-inflammatory monocytes or platelets disrupting this mutated endothelium causes increased risk for thrombosis through exposure to the basement membrane and a recruitment of inflammatory cells. And finally, vascular tone in the splanchnic bed, which is really responsive to histamine and nitric oxide signaling, can also cause changes to the vascular response and increased risk of thrombosis. So all of these different things come together to cause an increased risk of thrombosis. So just as an interim summary, just to catch everyone up, MPN patients are at an increased risk of splanchnic vein thrombosis, particularly with proliferative versions of the disease, meaning essential thrombocythemia and polycythemia vera, as well as this MPNU, which we talked about. Epidemiologically, it follows a paradigm where young patients are more at risk than old patients, and female patients are more at risk than male patients. MPN splanchnic vein thrombosis rarely resolves with anticoagulation alone and maybe a negative prognostic factor. And the fact that it doesn't resolve with anticoagulation is really a reason that people like Dr. Patel, who's going to be speaking in a little bit, get involved for interventional radiology interventions. And then JAK2 mutation can be found in the endothelial cells of the splanchnic vasculature and increases cell adhesion molecules, including P-selectin. So I'm going to walk you through the diagnostic evaluation. In terms of imaging modalities, there's several that we employ. Doppler ultrasound, which is inexpensive and convenient, but it's very operator dependent and doesn't capture the mesenteric veins. Abdominal CT, which visualizes the entire splanchnic bed, but it exposes patient to ionizing radiation. And abdominal MRI, which can really evaluate the soft tissue the best, but is a lengthy exam. So again, because of the central role of the JAK2 mutation in the pathobiology of splanchnic vein thrombosis, it's no surprise that if you look at MPN bug Chiari patients, nearly all of them are JAK2 mutated. In this meta-analysis, it was 87%. And in our institutional experience, it was 96% of patients have a JAK2 mutation. This is in contrast to patients who don't have a defined, pathologically defined myeloproliferative neoplasm, but have Budd-Chiari syndrome. Even in those patients who don't have an MPN, 70% of these have been found to have a JAK2 mutation, either in the form of a JAK2 chip or a fumfrost of MPN. So we did this study to look at what's the impact of testing for a JAK2, and we looked at our portal vein thrombosis patients and who had thrombophilia testing. And what we really found is that while many other thrombophilia testing, different testing modalities were employed, some of them had much higher positive rates. the one that really changed management by guiding new diagnostic or therapeutic evaluations was the JAK2 mutation. So evaluating the JAK2 mutation is probably the most impactful decision whenever someone has a portal vein or splanchnic vein thrombosis and doesn't have an MPN. So we encourage almost all patients with splanchnic vein thrombosis to have JAK2 mutational testing. Other driver mutations that we spoke of are less frequently positive. This is a meta-analysis that looked at the presence of the calreticulin mutation in MPN patients, which was only found in 1.5%, so much less frequently. And even among patients who don't have a JAK2 mutation, the presence of the calreticulin mutation was only about 3.7%. So much less frequently. JAK2 is by far the most common. There's other mutations outside of JAK2, CALR, and MPL. And this study looked at a group of patients who had either idiopathic or local non-cirrhotic splanchnic vein thrombosis. And they evaluated with next generation sequencing, looking at a number of different genes, and found that about almost 38% of patients have one of these high molecular risk variants, which they list here at different frequencies that you can see here, including TET2, DNMT3A, and ASLX1. And when they looked at time to recurrence of a splanchnic vein thrombosis, the patients who had these different non-driver mutation, high molecular risk variants had a significant increase in the time to thrombosis. So currently, Lenny Namagon is trying to recreate this experience within our institution by sending more next generation sequencing on these patients to see if we can identify these non-driver mutations and if these are patients who we may want to intervene on earlier on. So I'm going to shift gears and talk about treatment. And I mentioned earlier that the patients who have MPN splanchnic vein thrombosis rarely resolve, but there is still a benefit to anticoagulation therapy. So this is all splanchnic vein thrombosis, not just MPN patients. But what it really showed is that in a multivariable and univariable analysis, this is a patient-level meta-analysis, that anticoagulation therapy was associated with a decreased risk of recurrent thromboembolism, and not just recurrent thromboembolism within this splanchnic bed, but also outside the splanchnic bed. So also patients who have DVTs or PEs, anticoagulation therapy prevented those. It also decreased the risk of major bleeding and had a significant mortality benefit. So this is to show that in the splanchnic vein population in general, those patients who have thrombosis in the splanchnic bed, anticoagulation should be given in all patients, with rare exceptions for patients who can't tolerate anticoagulation for a number of reasons. Lenny also did this study where he looked at different types of anticoagulation in portal vein thrombosis patients and found that DOACs and enoxaparin have a significant benefit in terms of the probability of resolution of the portal vein thrombosis versus warfarin or no anticoagulation at all. So this study really shows that DOACs are not only effective, but also in a separate analysis are also safe. So we really encourage DOAC use and enoxaparin, which has really also now been adopted by different guidelines as well, to put DOACs and low molecular weight heparin up front, even though they haven't been tested prospectively in this population. We also think that anticoagulation may reduce the rates of chronic portal hypertensive symptoms. So these include ascites, as well as hepatic encephalopathy. And these are things what this study showed was with portal vein thrombosis patients who got these different anticoagulation strategies, your risk of having chronic portal hypertensive symptoms was significantly lower if you gave anticoagulation versus if you didn't. Now, cytoreductive therapy is really the mainstay of treatment for higher risk patients who've had a thrombosis, who have polycythemia vera, essential thrombocythemia. And this is a large study out of Italy that looked at 1,000 patients who had thromboses and then followed for years, had an MPN and then had thromboses. And they looked at the rates of recurrent arterial thrombosis with hydroxyurea, which is the mainstay of cytoreductive therapy in many of these patients, versus no hydroxyurea. And as shown in this top cumulative incidence curve, is that you have a significantly less risk of developing a recurrent arterial thrombosis if you give hydroxyurea versus if you don't. And they also showed this with venous thrombosis, where you have a significant decrease in the hazard of developing a recurrent venous thrombosis if you give hydroxyurea versus you don't in this retrospective series. But most pressing, what they showed here is that if you give hydroxyurea and you just look at patients who have splanchnic vein thrombosis, there really appears to be no difference in the recurrence rates of venous thromboses. So if in a specific population of splanchnic vein thrombosis, it's not really clear if hydroxyurea reduces the risk of recurrence. In our series, we also looked at if cytoreductive therapy impacts portal hypertensive symptoms, and we used a composite endpoint. And we found that patients who were on different cytoreductive therapies didn't really have a difference in terms of the development of chronic portal hypertensive syndromes if you weren't treated at all, albeit a very small sample size from a single institution study. In prospective evaluations, cytoreductive therapies outside of hydroxyurea have been evaluated. This is a study from Italy looking at ruxolitinib, which is a JAK1/2 inhibitor that we use for polycythemia vera, failed hydroxyurea, or myelofibrosis. And what they did is they looked at spleen volumes and symptom scores and showed that ruxolitinib successfully reduces the volume of the length of the spleen, so it shrinks spleen sizes and improves symptoms over time. But they also looked at echo Doppler analysis and showed that the venous thrombosis generally remained stable through the time, and there was no recurrence of splanchnic vein thrombosis. But they also looked at the resistive index of intraparenchymal splenic hepatic artery, as well as this pulsatility index of mesenteric artery, and that didn't change over time. So it's not like ruxolitinib makes the splanchnic vein thrombosis go away, but it also didn't recur. This is a study through the MPRC by my mentor, John Mascarenas, that looked at interferon therapy in MPN splanchnic vein thrombosis patients with PV or ET and showed that patients generally didn't have improvements in symptoms, and many of the symptoms actually got worse related to the interferon, including injection site irritation and blurry vision. But during the median follow-up of over 2 years, there was no recurrence of the splanchnic vein thrombosis. But again, these are smaller studies in a short time period to really evaluate this. So my second summary, just to catch up with this last point, is evaluation of most new splanchnic vein thrombosis patient and non-MPN patient really should involve testing for JAK2. Non-driver mutations may also be prognostically helpful, although this remains to really be fully evaluated. DOACs and low molecular weight heparin are really the preferred anticoagulation in this population over warfarin. And the role of cytoreductive therapy in reducing recurrence and portal hypertensive symptoms remains unclear. So with that, I'm going to hand it over to Dr. Schiano, who's going to talk about hepatic optimization and liver transplantation.
Hi, good morning. Hepatologists and our experts in MPN share a lot of patients. There's a full spectrum of liver disease that occur in these patients. I think the most common thing we see is non-cirrhotic portal hypertension, where on imaging a liver may look cirrhotic, but the liver tests are only minimally deranged and the liver synthetic function is normal. If you biopsy these patients, you will see NRH or OPV, both causes of non-cirrhotic portal hypertension. When patients have a cavernous transformation of the portal vein, as Doug alluded to, this denotes chronicity in the development of the thrombosis, and rarely this cavernous transformation of the portal vein can actually cause biliary obstruction when the thrombosis is at the liver hilum. Budd-Chiari is the thing we see mostly in the acute setting, and this could be an emergency, and patients may require transplantation at times, but more often than not, we refer them to our incredible interventional radiology colleagues in the acute setting. However, you can also have a more chronic Budd-Chiari that's sometimes difficult to identify. Patients may look like that they have cryptogenic cirrhosis, chronic liver disease, and you have to work them up a little bit further. Finally, we see people who also have SOS related to their MPN. Doug mentioned Jakafi. We found that a mild liver chemistry test, a DILI, can occur related to this medication. And anecdotally, there may be some weight gain associated with this medication that leads to fatty liver. I would say in biopsying many of these patients, maybe the most common reason we find abnormal liver test is NAFLD, which is, as everyone knows, sort of an epidemic in the United States in adults. We see extramedullary hematopoiesis that may be a cause of abnormal liver test, and then rarely we see a leukemic transformation. So very often we need to biopsy these patients when we're not sure what's going on, and we use the transjugular liver biopsy route. Next, please. So how do we optimize the liver disease in these very complicated patients? Well, what we tell our patients is really optimal treatment of the underlying hematologic disorder is paramount, and that includes anticoagulation and cytoreductive therapy. Although, as Doug mentioned, the studies really don't show unequivocal benefit to both of these interventions. We evaluate the abnormal liver chemistry test that these patients frequently have. We get FibroScans, which is transient elastography, and transjugular liver biopsy, as I mentioned. The typical profile is a mild elevation in the aminotransferases and the alkaline phosphatase level. Rarely do you see an elevation in the serum bilirubin. Many of these individuals have portal hypertension that is seen radiologically. So that's part of the management is screening for esophageal varices with upper endoscopy, and if present, optimizing their beta blockade. I think this is really important because if patients have a portal vein thrombosis or a more extensive portal mesenteric thrombosis, if they come in urgently, bleeding in the middle of the night, we don't have a lot of options. TIPS may not be an option for these individuals. So really preventative therapy is most important. We get periodic abdominal imaging to assess the extent of the portal mesenteric thrombosis or in Budd-Chiari. And of course, if patients have any new abdominal symptoms, and we try to counsel them to really seek medical attention should they develop any new abdominal symptoms. I think most important is early referral to hematology and interventional radiology for treatment and contingency planning. Here we have a portal mesenteric thrombosis group. This is the website here. So often patients coming from outside of the institution try to see our hematology colleagues, our interventional radiology colleagues as well in a single visit. Next, please. Portal vein thrombosis typically is not a contraindication to liver transplantation, and in fact, about 10 to 12% of patients undergoing liver transplant have a portal vein thrombosis. This is related to the low flow state within the liver due to portal hypertension, and the fact that even though cirrhotic patients are coagulopathic, there is a propensity for thrombosis in these patients as well. However, if your portal vein is thrombosed and you have concurrent superior mesenteric vein thrombosis, this may necessitate multivisceral transplantation, and the outcomes are much less robust in this patient population. There really is no published data or information on long-term outcomes of these patients who have MPN who require a multivisceral transplant, the liver and the intestine. Most cases of Budd-Chiari can be treated without liver transplantation, and we can treat them with diuretics and with treatment of the underlying hematologic disorder. Probably the biggest experience looking at Budd-Chiari came from a German liver transplant center. And when they looked at their data, there was really no evidence of enhanced progression of MPN post-liver transplant. This is something we always worry about the confounding effects of immunosuppressive medication. And their patients had a similar long-term survival, whether they had MPNs or not. And hemorrhage and recurrent thrombosis really contributed to the mortality and morbidity in this patient group. Finally, as a hepatologist, what we're seeing more and more of is an increasing need to prognosticate liver disease in patients who have MPN who are going for an evaluation for bone marrow stem cell transplant in advanced cases of MPN that are refractory to the new medicines with clinical trials.
Great. We'll move now to Dr. Patel on endovascular treatments.
Thanks, Doug. So, portal vein occlusion sort of has been traditionally just considered a contraindication for TIPS, but I'd have to say over the last 10 to 12 years, we and actually the group at Northwestern have developed techniques to manage these occlusions and sort of create endovascular shunts. These include just general TIPS and sort of how we get them in, extended TIPS, which is probably the wrong name for them. It's probably better to call them sort of transhepatic mesocable shunts, and then sort of straight percutaneous mesocable shunts. Most of these techniques require some sort of access into the portomesenteric system, and in our institution, we typically do that sort of through a transplanchnic approach. And here you can see a video on the right where we've stuck a catheter into the patient's splenic vein through the spleen, and you can see the flow is kind of going in the wrong direction here. Next slide. So this is actually a patient that was sent to us through the portomesenteric thrombosis group, actually from, I believe, Delaware, and was sent actually for evaluation for a multivisceral transplant. This gentleman had a hypercoagulable state, which I believe was a JAK2 driven, and he had chronic occlusion of his portal vein extending through the portal confluence into the splenic veins and cavernous transformation. So as Dr. Schiano sort of alluded to, these patients would typically not be an isolated liver transplant and would require a multivisceral transplant. And it's a little bit difficult for these patients because, their liver function themselves is actually normal, their bowel function is normal, but you can't really transplant just the veins, you have to transplant everything it's attached to. And so that's sort of a very big, relatively morbid procedure. And, so we've developed these techniques to sort of avoid the multivisceral transplant. Next slide. And so you can see in this patient, we were able to get from the splenic vein into the superior mesenteric vein and sort of the direct injection there. You can see this extensive cavernoma going up into the right upper quadrant. And the next video will play, I think. Oh, sorry. It's okay. Oh. There we go. And so we were able to create an extended tip. So there's a pigtail catheter into the SMV, and you can see this sort of this brisk shunt going out. And we're able to create a shunt and decompress these patients. In this patient and a lot of the patients we do see them in conjunction with the transplant surgeons as well. And if they can get a surgical shunt, for some of these patients, we may do a surgical shunt. There is a different procedure for some of these patients called a Segura, which is a different type of surgical procedure. But we do see them all in conjunction to try to sort out what would be the best option for these patients. Next slide. So, and we've created mesocable shunts. So this is a patient here. You can see basically connecting the IVC directly to a branch of the superior mesenteric vein. Again, these patients typically would not be a surgical candidate for a traditional mesocable shunt. We've actually had very good results. We don't do these very often. We probably have a handful of patients, although we still actually have the biggest experience probably in the world with these, but maybe only about 6 or 7 patients total. But we've actually had very good results and really good patencies with these shunts. Next slide. So this is sort of our experience. We looked at this about 3-4 years ago. This is all the patients with portomesenteric thrombosis that we've seen that we did endovascular shunts on. We had about 18 non-cirrhotic portomesenteric thrombosis patients at that time. These included the JAK2 patients and patients with myeloproliferative disorder. And these are sort of the shunts we were able to create in them. You can sort of see sort of the breakdown of the shunts. Next slide. You can see, so basically about 11 of them had known hypercoagulable state. And you can see sort of the extent of what the indications were for the procedure. Next slide. Technical success was about 100%. There was no related adverse events during the procedure or deaths. The reintervention rates is actually typically higher than we would get with a normal TIPS in a sort of cirrhotic patient. Reintervention rate was about 28%, and sort of the median length of times for reintervention was about 6 months. Next slide. And you can see sort of our patency rates here. So secondary patency rates at 12 months is about 86%, which is actually fairly good for these patients. Next slide. Yep, that's it. Yeah.
Great. So just some conclusions from our overall talk is that MPN splanchnic vein thrombosis, it's a rare complication with a very well-defined epidemiology and a now increasingly but still poorly understood pathogenesis. Anticoagulation is key to the reduction of recurrence and portal hypertensive symptoms, but the role of cytoreductive therapy at present is still less clear. Recanalization rarely occurs, and endovascular therapy should be considered early on in the patient's course. And I hope I got across that we got across that multidisciplinary collaboration is really essential for this complication in particular. And at Mount Sinai, because we have a world-class MPN center, a world-class liver transplant and a hepatology department, and world-class interventional radiologists, we're really uniquely suited to intervene and treat these types of patients. And we have a liver thrombosis program, which is becoming increasingly recognized as key to success for this condition. So with that, I think we'd like to have some thank yous. I've put some people from the MPN group, including my mentors, John Mascarenas and Ronald Hoffman, as well as the rest of the liver thrombosis program and biostatistics who have been key for helping us out with a lot of our analyses. So this is also my email address if anyone has any additional follow-ups or wants to discuss any patients or research ideas. And with that, we'll end and take any questions. Thank you.
Great. Thank you all very much. That was a really nice multidisciplinary overview, Doug, of this topic. So really appreciate it. So I invite questions into the chat. I see what looks like we have one already, Doug. For Dr. You want to read the question, Dr. Patel?
Yeah, so can you please comment on timing of intervention in relation to acuity chronicity for portal out of PVT? We generally think it's better to intervene in the acute setting, but your presentation suggests that doing your interventions, even in those with cavernous transformation, is it ever too late to intervene? So yeah, so it's a good question. So we typically see patients in two ways, right? So we see patients that have acute portal vein thrombosis. It is a little bit easier to intervene in patients with acute portal vein thrombosis in the sense that it's easier to cross all of these occlusions with soft clot. But it does add a little bit of difficulty because we have to give anticoagulation or use some sort of TPA to remove the clot there. So it does make it a little bit more tricky, but we've definitely done that for acute portal vein thrombosis. We tend not to do it at an immediate presentation. We do actually try to give them a trial of anticoagulation to see how they do. And it's not necessarily to get rid of their clot, it's to see if their symptoms resolve. So we're not necessarily treating the blockage or the thrombosis, but we're really treating the symptomatology that they may have. Although I have to say that the majority of our patients that we do see are sort of the chronic patients. And so that's where we've sort of pushed sort of the envelope in treating them. It can be more difficult because some of the veins that we would use to access or use to tie in go away, and that makes it a little bit trickier.
Yeah, and I'll also add too that among MPN patients who have a newly diagnosed splanchnic vein thrombosis, about 30% had evidence of cavernous transformation, suggesting that these patients may have had a portal vein thrombosis beforehand, was undiagnosed, had cavernous transformation. By the time it's detected, it's already in this kind of chronic state.
Other questions?
So, Doug, actually, I have a question for you. So, you said basically about 40% of patients with myeloproliferative disorder will present with splanchnic vein thrombosis. So the other 60% who don't, do you put them on anticoagulation, to prevent thrombosis?
Yeah, so are you primary prophylaxis for MPN patients to prevent? Yeah. So in general, the field of thrombosis prevention and MPNs is very poorly studied. And there's lots of publications, lots of studies, but a lot of it is retrospective studies. And the prospective long-term studies that are needed to really understand a low event rate, long period of time follow-up type event as thrombosis just haven't really been done. So at present, we don't employ anticoagulation therapy prophylactically for primary prophylaxis, but we do employ antiplatelet therapy for all patients who have a proliferative version of MPNs. So that is patients who have essential thrombocythemia or polycythemia vera almost universally get antiplatelet therapy with low dose aspirin. Now, if someone does have any sort of thromboses, for secondary prevention, they stay on anticoagulation lifelong, even if this is so-called provoked, where maybe they had a thrombotic stimuli outside of their MPN, like long plane flight or a surgery. We still think that the JAK2 mutation itself, the MPN and the inflammatory milieu really creates a lifelong thrombotic tendency. So those patients we generally place on lifelong anticoagulation indefinitely. Good question.
Yeah, that was a good question.
Doug, what do you tell your patients in terms of their life expectancy and, you know, what to expect? As you mentioned, a lot of these patients are young, and when I'm sharing patients with you guys, very often they're asking this question from the liver perspective, but what do you tell them overall?
Yeah, so there's been a fair amount of research into life expectancy, both ET and PV, and some studies would suggest that patients with essential thrombocythemia have a life expectancy that is no different than the general population. In polycythemia vera, patients generally are thought to have a lower life expectancy, but many of the patients who get diagnosed with essential thrombocythemia or polycythemia vera are diagnosed at a median age of around 60 or so. So someone who's 29 years old and gets an ET has a lot more life to kind of live rather than someone who may be 65 years old and gets it. So we generally counsel them that we don't yet know, and that the patients generally live for a very long time, on the order of decades. But the fact that they had a splanchnic vein thrombosis really puts them at risk for a lot of hepatic complications as well that we have to aggressively manage. And that the key to successful outcomes in these chronic myeloproliferative neoplasms is really close follow-up and earlier interventions, and to be involved at a program where we see a lot of MPN patients, and we're very much in tune to the latest research. But it is a difficult conversation to have, because in reality, it's likely that many of these patients who are younger will have a compromised life expectancy. To what extent that's going to be, we don't know yet, and it's poorly studied.
Doug, Dr. Kraft has a question for you.
Yes, hi, thanks. Excellent talk. I want to be sure I heard this correctly. So there's really two questions. So with this JAK2 mutation that kind of promotes thrombosis, is this something that you see across the board in certain disease states, or would it be worthwhile doing genetic testing to look for the mutation? And because you also talk about endothelial dysfunction as a maybe a mechanism for thrombosis, are you seeing thrombotic events elsewhere?
Yeah, these are great questions, Dr. Kraft. So outside of MPNs, the JAK2 mutation is also prothrombotic. And it's also important to note that the JAK2 mutation is present in patients who don't have MPN too. So in a large study from Copenhagen in Denmark, around 100,000 patients who were just taken from regular city health study had JAK2 testing and sequenced, and about 3% of them had a JAK2 mutation. And if you look at different CHIP studies, clonal hematopoiesis of indeterminate potential, and specifically the New England Journal one that linked it to cardiovascular events, the most potent predictor of cardiovascular events in these CHIP patients was a JAK2 mutation, and that JAK2 mutation CHIP. In terms of thrombotic events elsewhere, the main risk of thrombosis, or the main location of thrombosis in patients with a JAK2 mutation or MPN, is actually just arterial events and DVTs and PEs and other venous events, as well as arterial events, heart attacks, and strokes. But it is very common to have atypical site thromboses. So in addition to splanchnic vein thromboses, which is an interest of our group, there's also cerebral vein thromboses, which is at an increased risk in patients who have JAK2 mutation or MPN as well as other atypical arterial thromboses. So it's definitely something that we talk about. And trying to identify patients at risk for thromboses and MPN is a giant research effort in our field, and one that we don't have great methods to say you're at risk for thrombosis. At present, we have very crude methods based on age and prior thromboses for risk stratification, and more effort is being looked at different sort of clinical parameters, but it's very much in its infancy.
Got it. Great. Thank you.
With that, I'd like to thank Dr. Patel, Dr. Schiano, and Dr. Tremblay really for an excellent multidisciplinary talk. It was really great to have you all here talking about this from your perspectives and showing your terrific research program. So thank you very much. I also like to remind everyone this is our last grand rounds for this year. So we'll be on a summer hiatus through August, and we will reconvene after Labor Day. So have a nice rest of the summer, everyone. Stay cool and see you soon. Thanks again, everyone. Have a good day.